pleased today to bring in our guest speaker, who is the Hamlin McCarthy Quarterly Seminar yesterday webinar. He is an affiliate professor at the University, currently affiliate professor at the University of Washington School Department of Environmental and Occupational Health Sciences. He spent many years as a commissioned officer in the U.S. Public Health Service and the Center for Disease Control and Prevention and the Public Health Service, as well as NIH and a few other places. But he's going to talk to us today about health impact assessment as we move into the health impacts of the stuff we've been looking at. So, Dr. Dannenberg.
Thank you. Good morning or afternoon, or whichever it is, because that clock is still up. Good, I welcome the opportunity to talk to you all. I work at the intersection of health and built environment. Built environment I define as a range of issues. So it includes transportation, it includes what urban planners do, it includes what architects do, landscape architects. Sort of a whole range of what that physical environment around you is, transportation certainly being one part of that. I teach a whole course on health and built environment and sort of cover a lot of those areas. What I'll be talking about today is a particular tool that is used by public health in multiple other settings, and it is not limited to transportation or to built environment for that matter. It can be used in really any policies. In fact, it can be used in any sector outside of health to look at the potential health impacts of policies or projects outside of the health sector. So, for example, it's been used on things like criminal justice. If you give education to people in prison, does that end up improving their health and the job opportunities and things afterwards? So it can go a very wide range beyond transportation and beyond environment. Okay. So I want to start with just what is health. And I'm hoping many of you have seen this definition before. Is that the reason I use it is the broader definition. So health is not just the state of a complete mental and physical and social well-being, but it's not merely the absence of disease or infirmity. And so it gets into the livability and well-being, and so that healthier built environment. The wider issue on transportation and health, I know this course is focused more on the air pollution parts of health and transportation. From the circles I spend a lot of time in, we look at a much longer list of health issues related to transportation. And that includes the physical activity issues, the walking and biking, it includes all the safety and the crash areas. And it also gets into a much longer list. You get into noise and water quality, climate change, mental health, community connectedness, environmental justice, access to goods and services, disasters and resilience to disasters. So health is a much broader area that we focus on, where air pollution is one of the pieces. Why does transportation, so my primary background is public health, and one of the issues is what leads to health. And we use a term called social determinants of health, as some of you have heard of, and that looks at all those other sectors of society that influence health. And you'll see transportation is on the list, but it also includes things like housing and literacy and hunger and environmental safety and isolation and jobs and education. It's a whole range of issues that affect health, and transportation is one part of that as one of the social determinants of health. So I started at CDC about 20 years ago working in this area. And what we found early on was, in trying to talk to transportation people about health, we ran into a few barriers. And they're different worlds. And one of them had to do with language, that we use different words. And there were words like NMT, non-motorized transportation. Well, that means something in the transportation world, but in our world, why aren't we just saying biking and walking? That's what our side would know. And in the public health world, we use words like morbidity in the transportation world, so I said, what are we talking about? And then we run into things like the types of data that we're used to using would be different in the two worlds. So safety data, you can count how many crashes, or you do an intervention, and injury and safety pretty well overlapped, and we do something that improves the intersection and fewer people get hit there. But a lot of public health is looking at the longer term and chronic diseases. And so the data we have to show that, say, heart disease and diabetes went down over some long-term interventions, that didn't fit very well with the shorter-term transportation changes. And you also couldn't as directly link a change in transportation to a change in heart disease, because so many different factors add up to some of those diseases. And the other thing we ran into from the transportation people when we first started was, well, health is not in the mission of my department. Why should we talk to you? Go play in your own sandbox, and we do our thing, you do your thing, and why are you even talking to us? And that has definitely gotten better over time, that we now spend more time talking to transportation people and much better understanding what those links are. And if you look at the mission of the U.S. Department of Transportation, you'll find that they're correct. The word health is not in that mission, but there's plenty of words in there that have health implications. So they talk about safety, which, the health and injuries, that's the same. Being efficient talks about, well, if you have an efficient transportation system, you have that opportunity for transit, biking, and walking, and as well as for cars. Talk about quality of life. Well, quality of life is very much a health issue, and things like clean air and less congestion is quality of life, but it's also a transportation issue. And then you'll see the word quality of life for all American people and communities, and that's an equity issue. And public health spends a fair bit of time looking at equity and vulnerable populations. So while the word health is not in that mission, the mission is certainly overlapping what the intent of public health is. So that's just a little bit of background. So what I want to spend the bulk of the lecture on is this tool called Health Impact Assessment. And I'll run through what it is, how it's done, and then give you some examples of how we use it. So one of the things we learned relatively early on is that for public health people to talk to the people who build the built environment, and that's transportation people, that's planners, that's architects, and others, is that we don't really have a way to convey our messages on what is healthy design. And so the idea, and this actually came from Europe, has been used for a while in Europe, was why don't we do what's called a health impact assessment? And the intent of a health impact assessment is, can we look at the proposal stage, meaning prospectively when there's a proposal for a policy or a project, can we look at what its potential health impacts are and try to make recommendations to improve that proposal in a timely way so that we can have a better proposal that's either promoting health or minimizes any adverse consequences that are there. So the formal definition coming out of the National Academies on health impact assessment is a systematic process. It uses different data sources, different analytic methods. It has input from stakeholders. You really want community involvement, which I think is common in the transportation world, to determine the potential effects. So this is, while something's in the proposal stage, what might happen if we go with the proposal as it is, of a proposed policy, plan, program, or project. So it is not limited to one physical thing you're building. It can be programs, it can be projects and plans. The potential effects on the health of a population, and then the next part, and the distribution of those effects within the population. And that's a critical part, because it's one thing to say what it may do to the whole population, but where's environmental justice? Are we affecting the more vulnerable parts of the population? So a large part of public health is looking at vulnerable populations. And it's really kind of the young, the old, the poor, those without much resources, those living in poor areas. What are the impacts on them? And so that's a very central part of public health and of health impact assessment, is those effects on the more vulnerable parts of the population. And then the final sentence is, the HIA provides recommendations to monitor and manage those effects, meaning can we make it a better proposal? Can we give some recommendations, try to make it a better proposal, and monitor what happens? So the vision is that transportation planners and other decision makers and elected officials will want to know something about the health impacts of the proposals that they're putting forward. for both projects and policies, and that's part of the decision-making process. Any decision process has a variety of inputs into it. Typically, health has not been at the table when those decisions are being made. And that local health officials who typically know their communities will have this as a tool to convey that information to those decision makers. It will put health at the table and ideally get a better informed decision. So here's the 6 steps. And have you all been exposed to environmental impact assessments? Has that been discussed some here? Okay. And I'll talk a little more about that in a minute. But it pretty well parallels how an environmental impact assessment is done. It starts with screening, which is to say that we have a proposed policy or project, and will an HIA be useful for that? If I have a project, patch 3 potholes in the road, that's not important enough to spend any time saying what are the health implications of patching 3 potholes. But if I have major plans to build highways, to put in a transit system, to make major differences, then that's on a large enough scale that that project probably is worth doing a health impact assessment on it. There are some projects where we don't really need it. If I'm going to build a bike trail, I know that's already positive for health. It's going to encourage people to bike and to walk. And it's probably a lower priority than to do a health impact assessment that's going to come out and say, yeah, the bike trail is good for health. We kind of know that without doing a full health impact assessment. But if I have the master plan for all the bikes in the city of Atlanta, it may be worth it because it could be in that master plan. There are ways to give better equity if we put a little more priority in some areas and a little less somewhere else. So there could be times there where even though biking is already positive for health, ways to improve it, particularly for the more vulnerable population. So that's screening. Is it worth doing the HIA? Second is scoping. Is once we have the project and have decided or planned and decided it's worth looking at the health impacts, which elements should we look at? And you saw that list of how transportation affects health. There's quite a few things on that. And we may not get to all of them. And so looking at what's it going to do to air pollution is certainly part of it, what's it doing to physical activity and to injuries and noise and so forth. And some of them are going to be more important than others. And so as you can only do a finite amount of time based on time and resources in a health impact assessment, the scoping will decide which factors should we be looking at. The third set is the assessment. So now that we are going to do the HIA and we've decided what factors to look at, we want to get that information about the population that will be affected, who are they, how many, where are they located in geography, and again, looking at vulnerable populations and equity issues being a very important part of the assessment. In some cases, that data is readily available. In some cases, you're going to need fresh data assessment or take the best guess as you can. It just depends what the project is. Then after you put that information together, have an idea of what's there and kind of a baseline and what might happen if the proposal goes through, we then come out with recommendations. And the recommendations relate to take that proposal, how could we make it better? What things could we change that would make it more equitable, that would promote health? Or if there's things that you can't stop, are there ways we could minimize the adverse health consequences? You'll get examples of all these. This is kind of the overview of what's there. But basically, you want to promote health and mitigate harm. Once those recommendations are together, we have reporting. So we need that information to get to somebody who can use it. And so that involves getting those results to those decision makers, which may be a city council, a zoning commission, a regional transportation authority, depends who's making those decisions. But that becomes very important to get that information to those decision makers, because having a report that sits on the shelf, it basically has no impact. And then ideally, but often not done, is the monitoring and evaluation. Once those recommendations are out there, to see what actually happens, get different groups to actually do some follow-up and see how well those recommendations move forward. And all these slides are on your campus websites, right? Most welcome to take notes, but anything you don't get, if I could change the slide and see people always frantically writing, you get something off the slide that you do have them. Okay, so a number of issues immediately come up as we started looking. So we started looking at health impact assessments in the U.S. probably about 15 years ago. And over that time, they've caught on in some places more than others. But various issues came up. One is, should they be voluntary or regulatory? And if you're aware of environmental impact statements, they are regulatory, you're required to have them for major projects. And there's a bit of pushback because they can get fairly expensive. I heard there was one, I think, environmental impact statement for Los Angeles airport expansion, so it's like 100,000 pages and cost millions of dollars. I mean, you don't want that type of thing. First, nobody's going to read it, but they get so complex they become a barrier to get anything done, and there's going to be pushback to even have HIAs like that. So what has actually happened in this country is that most HIAs that are done, most, not all, most have been voluntary. And what that means is that a health officer or an advocacy group or an academic group or government group that wants it to happen goes and gets it done. It's not regulatory. It's simpler, it's less expensive, there aren't lawsuits over it, anything's regulatory, you can end up in court, spend a whole lot of money on that. And it's more politically accepted when it's voluntary. The big problem with voluntary is that the results are less likely to be used, so that the decision-making body can say, that's a very nice HIA, we're not interested, you can't make us read it or do anything that you suggested. So that where it has been voluntary, when you have the buy-in of the decision makers, they make a better decision and accept it, but there's certainly been other cases where the decision makers just weren't interested, and because it was voluntary, they could say, that's nice, and ignore it. On the other hand, if you go to the regulatory setting and model it on environmental impact statements, it becomes more complex, more expensive, litigious. A lot of things can end up in court because they're arguing over the wording there. It's less politically accepted because it is regulatory, but it's more likely to be used if you make it regulatory. So there's really some tension there. Should it be voluntary or regulatory? I think in a general anti-regulatory environment, it's going to be really hard to require them. So the ones that have been done have been mostly voluntary, and what you'll see in some of the examples is that many of them do get used. But it also means there's lots of places where they're not going to be done. They don't require it. So talking about how they could fit with an environmental impact statement, if you read the rules under which environmental impact statements are read, the health components could fit logically and legally within the EIA process. There's a number of words in the National Environmental Policy Act that talk about health as one of the things that we look at. In fact, what typically has happened, but that would make HIA regulatory if you got it in with the EIA. And what typically has happened is that the health part of EIA, it will talk about health, it will talk about air pollution, but it won't take that next step to say if the air pollution goes from this many parts per million to that many parts per million, that means health will change this many extra cases of asthma or whatever. It doesn't actually get, air pollution itself is not a health outcome. Air pollution leads to health outcomes, but EIAs typically don't actually then try to translate that, how much extra healthcare costs, how many extra cases of particular disease will come from that. And so that's where EIA goes sort of part way toward looking at health, but doesn't actually translate it into disease outcomes. We do have some examples of where HIA has been successfully incorporated into the EIA process. And so we do have some success stories of doing that. The other thing that comes along that has been very difficult, and it sounds like you're doing a lot of modeling with real numbers on air pollution, but it's hard on some other health outcomes, is that a lot of health impact, it's easy to do qualitative but not quantitative. So I can describe the direction, but not the magnitude of the results. And a simple example, it's easy to predict. I build a sidewalk, more people will walk. There's no numbers in that statement. And my problem when I do that is say, yes, a sidewalk will get more people to walk, is I can't do a cost-benefit model because I don't have any numbers to go with it. So if I want to go quantitative, I need some fairly fancy models, and it sounds like you've been working with a number of models on air pollution. There are some rather sophisticated models for air pollution, but it's difficult to obtain data. And in fact, if you said, I'm going to build this path, how many people will use it? Probably the best I can do is look at the last 10 paths that were built and say, how many people use each of those. And the answer on this new path is somewhere between that low number, that high number, and it's not a very close way to estimate, because we don't have good models that say how much, any bike path or other things will be used. And so, and ideally, if you want to translate that to health, you might, build a sidewalk, and 300 people who live within 200 yards will walk an extra 15 minutes a day, and they're going to lose 7 pounds of their average weight, and I'll prevent 4 heart attacks over 10 years. I mean, that kind of modeling has so many assumptions and things in it that we just don't really have models that I would trust that could get you that far, because there's just so many unknowns. So, even making a statement as far as what's there, and then trying to translate that to health is very difficult. For some things, we do have some data to go on. So this is some data we looked at from National Household Travel Survey, looking at people who use transit, and found that this was the survey is several 100,000 people, of which there were 3,000 transit users. And we found a median of 19 minutes a day of walking to and from transit, because most transit trips people walk to or from one or both ends of it. This was with, I think, 2001 data. We repeated with the 2008 data, and just recently finished it with the 2017 data. The data stayed similar as to if you use transit, it is likely you walk or bike to one or both ends of your transit trip. And roughly a quarter to a third of transit users get at least 30 minutes a day of walking. So we can say that if you build a transit system, here's some numbers of about how much extra walking, and we know there are health benefits from it. So some things do have numbers, but a lot of the health benefits on many of these, it's just very hard to put numbers on. One of the other issues on HIAs is having community involvement. So if you're proposing to build something, put a policy through, or whatever, you may hold some public hearings. For HIA, the ideal is that you would have that engagement, have some focus groups, have some public hearings, talk to people who are being affected, and it can identify both health issues and sort of the social issues. Now, in the EIA process, that's the norms to have these public hearings, and a lot of HIAs in Europe use that. The problems have been that it takes time and resources to hold public hearings. Often at public hearings, the people who are most vulnerable are probably least likely to show up. The people who often show up at public hearings are those with a very strong opinion one way or another. But the poor, the homeless, the people who are going to be affected by various decisions, they're not likely to be represented at a public hearing. You want them because you want that community input. I guess my biased view is that a public health officer who knows their own community ought to have a pretty good idea of what those concerns are for some of the more vulnerable population. And I would want some of that input from the health officer who had that awareness, ideally in addition to the community buy-in. But given that these things can get costly, it's, get the community input if you can. Sometimes the time doesn't allow community input. There are times, decisions being made in a matter of days or weeks, and you need sort of the desktop quick and dirty just to get some information there to try to influence a decision, but you can't have a process. Okay, so what I want to spend some time on then is we did the subset of HIAs that have been done on transportation. As mentioned, they have been used in many different sectors. They've been used in housing, education, and criminal justice, and land use choices, and many other areas. And so transportation is one part of it, and one of the larger parts have been transportation related HIA. So we did a review about 5 years ago or so, I'll show you the reference in a second. It said, let's look at all the policy and project HIAs that we could find. There's a group that's been sponsored by Robert Wood Johnson Foundation, Pew Charitable Trust, that put together a database of all the HIAs they knew of. The ANCDC had funded many of them. It's probably not a complete database because any community can do one, doesn't need to report it anywhere, so there's probably some out there we don't know about. And so what we decided to include to call transportation related were going to be the ones in which a transportation agency either was involved or could have or should have been involved. And so for example, if it's a road project or a transit project, that's a transportation agency. But something like building walking and biking trails could have come through a parks department, but because there's a transportation component, that certainly could count as a transportation related HIA. You didn't necessarily go through a transportation agency to get there. What we excluded was things along, say, a road corridor, where the road is transportation, but the development along it may have relatively little to do with transportation, but it's much more what's being developed around that corridor. Transit-oriented development is taking advantage of the fact there's transit there, but wouldn't necessarily have had a transportation component, because they're focused on the fact that transit station's already there, and it's the development around it that they got the HIA. So this was, what, 2014 we published this. It found 73 transportation-related HIAs have been done in the country. At that point, there will be a few more now. More on the West Coast than the East Coast. There have been some done here in Georgia and in the Southeast. But kind of scattered around the country, and some of that had to do with where there was local leadership that wanted it, some of it where the funding allowed it. The funding on these has been really quite a mix. So there's been some from CDC and some from Robert Johnson Foundation, but in Kansas, for example, there's a Kansas Health Foundation that was interested in this area, and so they funded a number of one there. So it's a real mix of who has funded these in different places. But some more on the West Coast where a lot of it got started, but certainly some scattered around the country. So that was 73 US-based transportation HIAs in the paper we did. And then a few years later, Wahi published in 2018, looking at what he could find around the world. So he got up to 158, and that was including US, Canada, Europe, and New Zealand. Still more than half of them were US, including the ones we found, plus a few more. And then he found some more in these other countries. So it's being used in different parts of the world. And then breaking down what types of transportation projects and policies we're getting, it's fairly split among different groups. So a number of them were transportation plans, some of them were policies, some of them were distinctly transit, some were just basically road and bridge development or redevelopment. Some were these corridors and transit-oriented development that had a major transportation component, and a few get into railroads and seaports and airports and trails and greenways. As mentioned, the trails and greenways are probably less important because they're already pretty much health promoting, so it's a little less important to what are the health benefits of something that's already kind of designed for health promotion. And then you'll see the second one there, the transportation-related policies, and here's some of the kinds of policies. So projects, you're building something physical, you can say, what's this going to do to the people around and the people who use it. Policies are a little harder to pin down of, what are the consequences, and often unintended consequences. It's really kind of interesting to see where does a policy go. So some of the types of policy, road congestion pricing, should we charge money for cars to be allowed to go into the city? What are the implications of that? So London has adopted it. I think New York and San Francisco, I'll come back to San Francisco in a minute, have looked at it, but as far as I know, have not adopted it. I don't know, other places considering it. I mean, it's been discussed in many places.
Singapore, yeah.
But Singapore has done it, and certainly discussed in other places, but has not caught on widely. But, that's the kind of thing. What are the unintended consequences? The people who need to be there and can't afford to pay it, but it certainly does affect, who can use it. Vehicle miles traveled, can we put, what are the policies to discourage that, and what are the health implications? A whole range of climate change proposed policies that relate to transportation. Transit fares, transit fares, the transit systems are chronically broke, never have the money they need, and yet the users of them often are the more vulnerable people with lower incomes, and so while we can raise transit fares to help the financial viability of the system, we can also harm low-income people who are more dependent on. I'll come back to an example of that. Things like speed limits. Okay, if we put in speed limits, what does that do? It can slow down the traffic. That may be good for pedestrians and cyclists. I mean, you would assume it would be. What does that do to congestion? What does that do to movement of people and goods that are dependent on being able to get somewhere? Complete streets. I don't know if you've talked about them. A complete street is one that is designed to handle all of the potential uses. So rather than designing a street just for vehicles, it looks just as much as how well is it going to work for pedestrians and bicyclists and transit as well as cars. Safe routes for school, I'll come back to an example of that. And even airport procedures, and how do you get people into airports and away from airports, and transportation systems there, and noise and pollution, a whole range of issues around the airports all have health implications. There are examples of things that are in the policy realm that you can look at health impacts for them. So we looked at this larger set of transportation-related health impact assessments and said, well, which ones had collaboration with the Department of Transportation? And you think about it, so if you have a health department saying, I want to look at that project or policy, there's really no obligation to talk to the transportation people. You certainly could have a bunch of health people sitting down saying, I'm going to look at these and come out with some recommendations. The concern being that you can say anything you want, but the transportation people, if they weren't involved, have certainly less reason to care what you have to say. And so we looked at what does high and low collaboration look like. And so the ones where there was good collaboration with DOTs were, in some cases, it was actually invited by the DOT, in some cases even funded by the DOT, that there were meetings, that there were people in the room from health and transportation that were sharing data, if they were listed as a co-author on the report, or there's a transportation planner involved. So the ones where you could see transportation was part of the project. For the most part, in reviewing HIAs, what we had available was that final report, and that's 25 pages or 100 pages or whatever, and you could look through and look for evidence of DOT involvement. We did not, in general, go back and call them up and say, did you talk to somebody at DOT when you did that? So if they didn't document it in the report that came out, we usually could have missed something. The low collaboration level was the opposite, that they barely mentioned the DOT or they had anything to do with it. They didn't ever, they might have had one DOT on some advisory committee that barely meant, but it isn't being mentioned otherwise, and there was no funding and no real engagement from the DOT. And the thought being that the more they're involved, the more they're going to look at results. So that second article by Waukee that I mentioned actually tried to see, could you show that having the DOT involved mattered? And it's easy for me to say, of course it matters, if the DOT is there, they don't listen to it more. And what he was able to do was, for the 147 that he could get information on the impact of the HIA on the final decision, or the subsequent decision, was only available for 19% of them. Because for the most part, when you look at that report came out before the decision is being made. And unless you have a way to go back and then have the resources to go call up and say what actually happened and was it influence. And there have been a few studies like that where you can go back and say what happened later. So he was only able to find information on 19% of them, but of the ones that he could find information on what difference did the HIA make on the subsequent decision, he found that there was a significant difference, that the ones where there was some transportation planner involvement or DOT involvement were more likely to listen to the recommendations. That's kind of what you expect, but at least there's a little bit of data supporting that notion that transportation should be involved. It's nice for health people to think we know everything. Obviously we don't, and the more engaged that we can have transportation people, the more likely that the recommendations will carry some weight. So what I want to do is run through 8 different HIAs, and the first one is one you hopefully know reasonably well because it's local. And this was the Atlanta Beltline in about 2005, about 15 years ago. I was at CDC at the time and worked with Catherine Ross, who's here at Georgia Tech. And she got money from the Robert Wood Johnson Foundation and with some help from us at CDC to do a rather in-depth look at the Atlanta Beltline proposal. And at the time, you all know the history of it. It came out of Georgia Tech. Ryan Gravel was a master urban planning student who proposed the whole thing and has since taken off and doing a very substantial project, as I'm sure you know. And so working with Catherine, and she had a lot of good contacts. She had been the head of regional transportation.
And yes,
Georgia Regional
Transportation
Authority.
Greta,
whatever. So she knew all the plans, first name basis with the mayors and the governors and everybody else found it along the way. So one of the nice things working with her is not only could we get the information we needed, but as the results coming from the HIA, she was going to be talking to people who were making decisions. And that really strengthened this as it particularly well about the HIA. She had a number of graduate students working with her, and they could get the data, they could use GIS and lay out who's going to be affected where, and we could look at a whole range of issues on what the Beltline would do. And so what happened from that, a lengthy report of a few hundred pages, we spent a lot of time going through the recommendations. And what happens out of HIA is you end up with lots of recommendations, dozens and dozens. You kind of have to weed through them and think, okay, what are the most important ones? And so you end up on these documents, it can be 100 or several hundred pages. You want an executive summary because you know perfectly well no one's going to read 100, 200 pages. They will read the executive summary. And so we worked hard to pull out from all the recommendations of how the Beltline could be done, of what are the most important ones. And one of the nice things on the Beltline is that we knew it was positive to start with. It was going to encourage walking and biking and transit and redevelopment and jobs and all sorts of good stuff just by the nature of what was there. So we knew it was going to have positive results. But I don't know the right words, fine tuning. There certainly were elements that needed to be decided. It's a multi-billion-dollar project over many, many years. There's a lot of decisions that were made over time. And so to try to have those decisions, those kind of subsets of the big one, the big decisions that I could put forward, to make them as helpful as possible. And so some of the accomplishments that grew out of recommendations, there was a decision support tool being used that was going to guide some of the many decisions that had to be made as they put the Beltline together. And out of the HIA grew the idea of having the health issues be considered in that decision support tool. There was a push from the HIA to get the parks and trails done early. Because at one point it could have been all transit first and parks and trails later. And so there was a push that's going to have more impact getting people. All we've been on the Beltline at some point. I mean, it's very well used, almost overused practically from the day that it opened. So that was one of the recommendations: get them out there, get them people using it, enjoying it, and that also helps build community support for keeping a big long-term project going. Another element was, can we get some public health professionals into some of those decision-making boards and advisory committees? And so when you have that large a project, it's not a one-time decision, and some of the other ones you'll see are more go, no-go kind of one-time decisions. When there's going to be a lot of ongoing decisions, get some public health expertise at the table, and so that many of those individual decisions will be more favorable to health. It also, by saying, hey, this is good for the city and good for health, helped get some more resources for the project. They're able to get some more money to help some of the trails get built or behind them. And a big thing that this HIA did, and a lot of HIAs do, is it raises the awareness of health issues among the decision makers and stakeholders. So just having that information in front of those decision makers, they're thinking more about health, and it's got a better chance of being at the table and getting more favorable result. And so the current status, you all probably know, living here, is that the initial parks and trails have been built, and the transit component is still being planned indefinitely.
Definitely planned.
Yeah, it's in planning, still a little fuzzy as to what's going to come of it. This is, 15 years after we looked at this, it's still a long time for the project, but it's still alive, I guess, for transit, but a little fuzzy as to what it will look like. So this is a case of, a major HIA took resources, took time, took money, but got some good messages out, and particularly with Catherine Ross having the connections to the people making the decisions, being able to get those messages across has led to some positive accomplishments from doing the HIA. So I'm going to jump back and forth to East Coast, West Coast. So another one I was involved in, I was actually still at CDC at the time, was a major bridge replacement in Seattle, right here where I live. This is a 520 bridge across Lake Washington. The bridge is maybe 2 to 3 miles long, crossing a major lake. And the bridge is maybe 50 years old and was, ready to collapse in the next earthquake zone. And, was not up to any kind of codes or standards in terms of being narrow, no shoulders, and no bikeways or anything. Its time had come, it's ready to be replaced. So in the funding for it, again, these are billion-dollar projects. You're talking, a 2-3 mile long bridge over water and all the access and everything has to go with it. Through whatever the politics were, and I'm still not totally clear what they were, actually one of the few mandated health impact assessments was done that the state legislature, as part of the funding to rebuild this bridge, said we want an HIA, and they asked that the health department and the clean air agencies that are very aware of the air issues would look at the project's effects on air quality, carbon emissions, and other public health issues. So we took the air quality part, which was the obvious part that you all have been focusing on, and we took that other public health issues to let us justify looking at that whole range of issues that are affected by transportation. And the funding was basically through the state, and they were collaborators in it. And did, again, a several hundred-page report, had a lot of information on it. It was interesting that equity was less of an issue because it was not going through particularly poor areas. It was not displacing a lot of people. It's basically a replacement on the land they already had. But there were a number of issues to be looked at, and there were things like getting a bike and pedestrian lane on the bridge that didn't have one. Issues of construction, noise, and air pollution on that. You point out here a lid over part of the freeway, so that they wanted to put like 5 or 6 lids on the ends of this where it got near communities that could kind of reach. This is a big road that will be 6 lanes plus shoulders plus bike lanes and so forth. So it gets pretty big, and so you can put a lid over it just as you have. Is that 5th Street?
Yes, sir.
5th has a very nice lid here, so those kinds of lids really add to community connectedness, make a much more pleasant neighborhood, you cut down on the noise and all sorts of issues. So that was in the design. So recommendations, in those directions, also recommending don't lose the good stuff. And what that means is when you cut down your budgets, you're always going to run out of money, everything costs more than you ought to. Well, why don't we just get rid of that bicycle path and use of that kind of stuff? Well, what was nice, at least in Seattle, when that was suggested, well, maybe they'll lose the bike path. They have to cut budgets, and someone said, wouldn't be tolerated here. It's because there's an active bike community that would be very local. The local bike club has 15,000 members and a $3 million budget. Well, the bike club has that. They're evident. They're at every meeting. They are very much in people's face. So you wouldn't lose the bike lane on a bridge like that. And so the recommendations that came out of the bridge HIA were supported by City Council and the teams involved. And for the most part, the proposal already was doing the right things. And so what came out of it, there certainly was raised awareness and more good conversations with the transportation people. Much of the bridge is now done, and pretty much the good features have been maintained in it. So it didn't make a big difference, but it kept the good stuff there, and it certainly helped with communication in doing that. The next one I want to mention is the Baltimore Red Line. This was a transit line to run east-west in Baltimore. It's something that the city really needed. There was good cooperation between the city Department of Transportation. They got a public health person working for the Transportation Department. That's really unusual. I mean, they are crossing agencies and getting people to work across. Had good staff support from the health department and the transportation departments working together. The line was serving a lot of equity issues among some vulnerable populations. Really would have made a big difference. It came out with some very good recommendations of how it would help health in some of the poorer parts of the city, access to jobs and services, and helping air quality and reconnecting neighborhoods. And this is one where the HIA was submitted as part of the comment to the EIA. So environmental impact statements, when they come out in draft, are allowing comments to be added. And so formal HIA can be gotten into the EIA process by just submit the whole HIA as a formal comment. Once it is submitted as a formal comment, the decision makers are required to reply to it and at least consider everything in there. They don't have to take all the recommendations that they're required to do it. And as a result, the city Department of Transportation accepted some of the recommendations, created a full-time position for health and environment, was looking at noise and air quality, was looking at green guidelines for it, and all of it was going great until, I love to say, it was a Republican governor who killed the whole project. And it just really was a setback for the city that, gee, we don't want to spend money on this. And it's something that the city would truly have benefited from. It was positive to start with, and then with some health recommendations would even have been stronger. It got killed, and those things happen, and you still, will it ever be resurrected if they get a different governor? I don't know, but it's really a big disappointment when the governor killed it. Those things happen. Another one, this one's California, East Bay Greenway, was looking at the idea that BART is their transit track. A lot of it's elevated in the East Bay. This is Oakland and Berkeley and Hayward, that side, across from San Francisco. And the idea that there's room under the tracks to put in the trail, you're seeing a little bit of it there, for 12 miles, which is a large part of an urban area for pedestrian and bike trails, it can connect neighborhoods. It was done by a consulting group called Human Impact Partners that's based in Oakland. And again, you expect a lot of positive things out of putting in trails, so looking at physical activity and social cohesion and some nice natural space. The two concerns that they raised had to do with crime and some of the areas that we're going through, and then still safety for motor vehicle crashes, whether bike and heads. And this, they really was pretty well accepted, so that the HRA recommendations did get included in the final plan. There's something called crime prevention through environmental design, which is looking at there are ways you can design things that make crime less likely. It's things like eyes on the street, making things visible so there's not corners people can be lurking behind to jump out at you, those sorts of things. So getting those principles built into the plan and getting better crossings for pedestrians and bikes and common traffic and urban rangers program, I think was kind of a safety one. And that project has now broken ground, and I've been on parts, but I don't know how much of it is built, but at least parts of it are built, and I think it is moving forward. But the HRA, helped make it a better project by looking at that. Next one I want to mention is the Safe Routes to School out of Indianapolis, and this was one where they were particularly looking at equity issues. So this came out of the Department of Public Health within the university. And they were looking at whether Safe Routes for School would help children in the Binford community, which is one of their low-income communities. Safe Routes for School has to do with safer crossings and sidewalks and ways to make it so it's easier and safer to walk and bike to school. It looked at physical activity and asthma and social cohesion and the things that you would expect. And not surprising, it found that in general it's going to be good for kids. You're getting them out biking and walking. You can help with asthma, air pollution, connectivity, and safety. It did find that some of the kids they had hoped to help would not benefit because either they went to a more distant school, they didn't go to the local school, or just they went to the local school that was simply too far based on what those distances were. Some of the recommendations that came out of it had to do with, well, let's get some more health data on the kids, and let's do some counts on walking and biking, and getting some grants for fixing the sidewalks, and having walk and bike to school days, the programming part to encourage kids, and it helped contribute to them getting some more money to help encourage the Safe Routes to School. So one that we know is already positive, but by bringing that extra, it made it a stronger program. Next one is a bike and pedestrian one. Again, anything that's a bike and ped is already pretty positive, but this had some benefits. So this is Clark County, Washington. It's Vancouver, Washington, across the river. It's in the Washington side. It's across the river across the river from Portland, Oregon. And they looked at what was in the plan and recommended a number of things with some health-based targets and how to prioritize some of the policies and looking at healthy food and getting health and equity in there, various safety things that you might expect on a plan that's already fairly positive. And then they did a formal evaluation to say of the recommendations they came up with, and these are not going to be radical, surprising recommendations, they're reasonable things that can enhance the program. They found that 8 of the 11 major recommendations were fully adopted. So the things they put out were in fact influencing that plan, and the other 3 were at least partially adopted. And for that, they actually got an award from the Active Living Research Group saying, translating research into policy, that what they had done by looking at that from a health point of view led to recommendations that actually got primarily adopted in the plan, so that we got an award for it. 2 more. This is San Francisco, the road pricing that we mentioned a minute ago. And the County Transportation Authority looked at road pricing and, could we charge motorists for coming into the city during rush hour? And the money could be used for public transit, road maintenance, and ped-bike improvements conducted by the Health Department with money from Robert Johnson. And they talked to each other. So in San Francisco, the Health Authority and the Transportation Authority did talk to each other, worked together, got the data, compared it to what would happen if you didn't put that in and came up with a group of recommendations of what the best way to use that money would be. And they're definitely looking at equity issues. San Francisco has been very good at looking at that. And so they were looking at what's the best way to do this policy. And I just got in touch with contacts there a couple days ago, and she said, yep, they're still talking about it. So it's been going on, and this was going back a few years that they looked at this, so it's not off the table, but it hasn't happened yet. But it put more information in front of them from that health point of view. And the last one I want to mention is out of Boston, and it's one which had very direct effects that made a big difference on vulnerable populations. And this had to be a rapid one, because it was a policy being proposed that was not going to have a lot of time to talk through, what to do about it. This was a proposal, the transit system in Boston. I don't know if you've been to Boston, has a fairly extensive transit system. It's kind of old and creaky, and like I said, maintenance needs and operational needs to keep it going. But it's a good system. It gets places. I like it. It works, but their budgets are always short, as many transit systems are. And so they were looking at how do we close those budget gaps, and so why don't just reduce service and reduce fares? That theoretically could close a budget gap, but who is most likely to suffer from that are your most vulnerable populations. So from an equity point of view, it's absolutely the worst thing you could be doing. And so in a matter of 8 weeks, because the policy was about to go through, this Boston group was able to do some modeling and put some numbers on what are these pathways to various types of health outcomes, including crashes and air pollution and physical activity, and quantitate both your health and economic costs and add them up. And these are all models that say different assumptions would give you a little bit different results, but they found that the estimated health and economic cost of the changes, which is raising fares and cut service, would be in the range of $200 to $300 million a year, which was higher than the dollars that they were trying to save by making the service more expensive and worse. And so they were able to use this information, and this did have to, was quantified, to advocate with the decision makers, and they were able to get much more modest. I mean, there's still going to be some changes because they were still, the system was broke, but they were able to get much more modest service cuts and fare increases because they were able to show that you're really not helping anything. In fact, you're actually going to lose money for society if you do radical fare increases and service cuts. So this is one where you really made a difference. This one you'll see a reference down there, so that whole process and how it made a difference is really not the whole picture. Okay, one other thing that went on in Massachusetts, which I think is kind of, I have to call mixed success, is Massachusetts is one of the few places that actually tried to require HIAs for transportation projects. So in 2009, so this is a decade ago, they adopted something called the Healthy Transportation Compact. And in it, it said, we require state agencies to implement health impact assessments for use by planners and transportation administrators, public health, and developers. And it was a very nice collaboration between the Department of Transportation and the Department of Health if it had really fully moved forward. So after it passed, they went out, they did a pilot study of this highway in Somerville, Mass, to kind of show what an HIA would look like. And then it just never really quite got implemented. So from what I can tell, and they have done a few HIAs since then, but it never really got to be this is the normal projects, lots of arguing over how to do it, who would pay for it, and which projects ought to have it and so forth. So it was a step toward regulatory HIAs, but it never really fully happened. Okay, I want a couple of final slides, and open. We have to 12:15.
Right.
1:15. I just want to mention a couple of related topics to HIA and transportation and health. One is that CDC has come out, and this is 9 years ago now, with a formal statement talking about those relationships between health and transportation, and it's to encourage states and communities to consider health as part of transportation planning, and that health impact assessment and safety audits can be useful for identifying where health fits in with transportation projects. So here's sort of formal federal government statement that health matters in transportation. To summarize some of what we've talked about, HIAs can contribute to transportation decisions I kind of selectively gave you some of the ones where it generally did make a difference. There's other ones where we can say really not much impact, the thing got done, and, you know, nobody was real interested in the results, or actually some other ones where it got done, it was well done, and, you know, politically, projects got killed. It's not that rare that those things happen. I would say that it is used for some transportation projects. I'm going to show you just numbers of the ones we know about, but certainly most of the time it's not widespread. It's not the norm that every, you know, environmental impact statements are under the law used regularly on, you know, many transportation projects. HIAs are still sometimes, but certainly not widespread. We know that the more engaged the transportation agency is, the more likely it's going to make a difference, and where you can, engaging it in the context of EIA can help. Some of the challenges in doing transportation HIAs, we mentioned before, quantitating, building those models can be really quite difficult. The resistance issue of experience that the EIAs have a regulatory burden and there's no pushback for doing it. Not a lot of people trained to do HIAs, so there's capacity issues, who pays for them, so there's resource issues, and then evaluation. Many of them have not been evaluated, ideally should be. Some of the strengths, it you know, brings attention to health and social inequities, gets health to the table, builds connections, can involve community engagement, has long-term potential to make a difference, and we can do them as whatever level of time and resources allow, whether it's more comprehensive or intermediate or desktop. Some of the concerns, as mentioned, quantitative versus qualitative, voluntary versus regulatory, how much community engagement, what kind of standards, since these are being done by many people, many places, they don't all match the same. You know, the general process is the same, but the formal standards are not all the same. The time and resources we mentioned, the timeliness, if you do it, you know, too late, the decision's already made. If you do it too early, too little is known about it to be able to, you know, be very meaningful. And then a big one is the sector bearing the cost is not the sector with the benefits. So the fact that from the societal point of view, we'll have some healthcare cost savings, that doesn't feed back into the transportation agency that didn't want to spend money. The road builder isn't better off because society saves some healthcare dollars, so it makes them, you know, less interested in seeing that. But some of the opportunities, you know, working within EIA, getting more rapid methods, building more quantitative methods, getting more awareness of HIA in public health and transportation departments, getting capacity there. There's a health and all policies approach that says that basically health ought to be considered in all parts of society. The definition that it's a collaborative approach that considers health in really all sectors, and that can be part of transportation being one of them for the betterment of that. Last couple slides, I want to mention there is a tool that was developed by U.S. Department of Transportation with CDC that looks at some of the measures and metrics that you can use for looking at health in transportation projects. Some of the kinds of indicators that are in that tool we need indicators that are already routinely collected. You're not going to have a lot of resources to go get new data. So some of the things that already are out there, things like commute mode share and alcohol impaired fatalities, and, you know, public transportation use and seatbelt use and road fatalities by mode and person miles traveled, land use affordability. So there's a whole range of data that already exist that when you want to look at transportation and health issues, these are ones that we know already exist. Also, just want to mention this report that looks at biking and walking in the 50 states and 50 largest cities that was put together by actually with CDC funding by the bicycling organizations, the League of American Bicyclists, that gathers data about how much walking and biking, so you can compare cities and states on how they're doing to other cities and states, and it's actually been quite useful because the city will say, how come, you know, we're sitting there at 49th out of all the states, we can do better. And so by putting those data in front of them, and even the ones who are sitting second or third, well, who's number one? Why aren't we number one? So is that we have, with some evaluations of this report, show that just putting that data in front of people has stimulated some improvements. And the last one is just there's all sorts of interesting ways to do research in this area. This was one done by Aaron Gipp, where he archived traffic webcam photos, got like 500 million photos out of, you know, these traffic cameras. And, where do you want to use them? Well, they built a bike lane in Washington DC, so we took the before and after traffic photos and put them on what's called Amazon Mechanical Turk. It goes online, and people in India at a penny a picture will go and count bicycles and pedestrians in your pictures. And so we put it up at a penny a picture, put 1,200 pictures up at a penny a picture, cost them a total of $12, and 8 hours later, all these counts are done. Because there's people in India who happy for that penny a picture, who see it as soon as it comes up, jump in and do it. So there's being able, anywhere else you would have had, get people out there watching and counting on the counter, and here for $12 in 8 hours, he was able to get, 1,200 observations of, did the bike lane actually increase? So there's creative things that can be done. So let me end with that, and we'll have a few minutes for questions. Here are two websites. HIA Society is the Society of Health Impact Assessment Practitioners. That has some information about HIA, and then Health Impact Project is the Robert Wood Johnson funded group that is doing a lot with HIA, so just more resources there. Time for questions, and I'm happy to answer anything.
Well, thank you very much.
Yeah, go ahead.
One thing you kept bringing up was safety. I was wondering if that is actually part of the health standards in the HIA, and also if it was incorporated on the belt line, similar to the way you mentioned crime safety was in the one California bike lane project.
Yeah, any of these HIAs in the scoping process will look at what is the range of health issues, and safety and injuries and crime routinely would be seen under scoping as one of the areas to look at. Now, in different ones, you'll have more or less information to go with. Certainly pedestrian, most of these have pedestrian bicycles somewhere in them, and so that type of safety is there. The crime part really depends on where it is it an issue of concern or not, but in scoping, that would routinely be one of the ones to be considered. So yeah, that should be. Other comments? Yeah.
Do you think an HIA encourage like a project that should be mandatory or voluntary?
For any project, you're going to run into the anti-regulatory backlash, and that's the short answer, is that if you could make them required, it could help health, but you're going to have a hard time ever getting it through. And that's, it's not required even in states that are more open to regulation. It still is not really required anywhere. Massachusetts was the closest for the transportation one, and it never really, they passed it, and then it never really got implemented. So, what I guess the best we can do is to say voluntary works if you can get people asking for them and funding them, and then trying to combine them with environmental impact statements where you can. Environmental impact statements tend to be funded because they are regulatory, but I think a overall regulation, everybody should do them on every project. I just don't think that's ever going to politically get through. So it's kind of a mixed answer. I mean, ideally, yes, of course, but in political reality, it's not likely to happen. So that's kind of a mixed answer, but an appropriate question. Yeah.
So in the weaknesses, you mentioned that it is expensive, and also there's not a lot of people who know how to do HIAs. So has there been any investigation into like making it just more well known, or like training other people who are already working in those departments?
Yes. So I actually teach an entire graduate level course on HIA. We get 20-something students, and it's a mixture of planners and public health students in there. There is a similar course. I think Nisha Northway is teaching one here on HIA. I can't remember what she's teaching right now. She has taught them before. She and Catherine Ross, I guess, wrote a book on HIA. There are courses around the country that teach them in school. There are and or have been a number of online courses. There have been short courses where, the health department, Department of Transportation wants it there, or people like the group I mentioned in Oakland and elsewhere that are happy to come out and do a 2-day short course for people working in the field. So we have done a fair amount of publishing in it. There's multiple books and articles in the field. And I give lots of talks on it, and so do other people. So gradually the awareness of it and the skills are there. My feeling, though, is that the level of training to do it need not be that complex. Because one time I had a phone call from someone who says, we'd like to do an HIA, I don't know how to do it. We spent about 10 minutes on the phone, which had the following conversation. Tell me about the project, blah, 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 here's the project, and what are your health concerns, blah, 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 and what would you think could be done to help those health concerns? Well, we could do this, we could do that. At the end of 10 minutes, I said, if you take everything we just said and put it in writing, you've done the first draft of your HIA. I mean, because it's really basically common sense. Here's how it might affect health, here's some things that will improve it. And my feeling is I would much rather see short, quick, and dirty that captures the main ideas, and not the $200,000, 300-page report that no one's going to read anyway. And I think that most health officers are informed enough about their communities that if you got a health person sitting down with a transportation person talking through what some of the issues are, there's a lot of common sense in there that you don't have to have a really sophisticated HIA to be useful. There are a few places that have gone to checklists. Here's the major issues, let's just go through the checklist. And that's not as sophisticated, but it captures the key messages. And you can do a whole lot more checklists than you can do, 100-page report. So to me, there's that whole range of level of sophistication, and I'm perfectly happy if you do a simpler one that gets done than the complicated one that doesn't get done. Good question. Yeah.
Being said, you still have to do your second project.
Maybe like a stretch, but do you think EISs could be like streamlined if they were voluntary?
If they were voluntary, they would not be done. And the reason is that the people who are building things want the minimum barriers. And, they really progressive place where I really want what's good for the community. Most of the people doing an awful lot of projects, I'm a contractor, and I want to spend the least money and make the most money to get the project done, because the sort of awareness isn't there. So I think you need something to encourage them. Now, whether it's regulatory or whether there's just ways to give incentives and disincentives. And I believe in working with the market, get the right thing done without super heavy regulation that really gets pushback. But if, for example, we say you do an HIA and we'll, make some other rules on you a little bit easier, or give you a tax break for whatever, make some things so it becomes attractive to look at it. I think you could encourage more of them to be done. But strictly voluntary, people who are only looking at the bottom line just aren't going to do anything voluntary. They don't have to, which is, why some have been done and there were years and years.
Other questions? All right, if not, go ahead.
Is there an example of a time where HIA was made and the health implications were just completely wrong and it ended up hurting a lot of people?
I would say, meaning the health implications were adverse, or they.
Like in the HIA, it said maybe
Did they give
this
them-
won't be that bad
yeah.
for people, and then in reality, when it was built or something was done, it was bad for people.
No, but I'll give you one example where the HI showed what they did not expect, and that was, there was one in Florida where they wanted to build a coal-fired power plant. This is probably 15 years ago. And the local people were very concerned on the air pollution coming from the coal-fired power plant. That's why they pushed for the HIA to be done. The HIA ended up saying, well, first, the air pollution is going to be strictly regulated to a level that really will not be. They had all the scrubbers and all the stuff that would keep it down. And this plant actually will give employment to a very low-income area. So there's some positives. So it was not what they expected when they endorsed it, and it went to that thing eventually got canceled anyway for other reasons. But it doesn't always say what you might expect coming out of it. I've not seen it where it caused harm, is I think what you're asking. Anything's possible, but I've not seen that, because for the most part, the acceptance of recommendations is voluntary. Since there's no regulatory force there, it's unlikely they would force through something that would cause harm, because it still has to be accepted.
Okay, any other questions? If not, we'll thank,
Okay.
our